Good morning, everyone. Welcome to Trends, our fall 2021 virtual conference. I am Marina Martinez-Kratz. I'm a nursing professor at Jackson College in Jackson, Michigan, and I'll be moderating this session. It is with great pleasure that I introduce our speaker, Brenda Nordstrom. She is going to present today on the relationship between trauma and pain. And if you were lucky enough, like I was, to catch her earlier presentation on human trafficking, this is going to be a nice segue into this presentation. So Brenda comes to us with 30 plus years in nursing from a variety of clinical settings. Ranging from pediatrics to geriatrics to summer camps to nuclear power plant. I love that. You'll have to tell us that sometime, that story. She's a certified hospice and palliative nurse and is board certified in pain management nursing. She obtained her Doctor of Nursing practice degree that included research on knowledge of human trafficking and the ability to respond within the healthcare setting. So without further ado, I'm going to hand it over to Brenda. Thank you, Brenda.
Thank you, Marina. Hi, as she said, I'm Brenda Nordstrom, and I do a lot of advocacy work within the human trafficking arena and advocating for trafficked persons. And along the way, I started to really understand that the link between the mental and the physical aspects of the pain experience. And so that has led me down this journey to really look at pain management from a non-pharm presentation here. So the objectives of this presentation are: at the conclusion of the activity, participants should be able to identify different types of trauma, understand the physical and the psychosocial effects of trauma, specifically recognizing how this impacts the pain experience. We're going to examine how assessing for trauma can improve current symptom management practices, as well as analyze the importance of utilizing a trauma-informed approach. So before we get too far, let's look at trauma. What exactly is trauma? Above all else, trauma is very, very complex. According to SAMHSA, an event, a series of events, or a set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening with lasting adverse effects. The APA DSM-5 also says that any event that confronts a person with death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence can potentially cause PTSD. So knowing that, let's look at the different types of trauma. When we break that down into the different types, we're basically looking at three categories. First is the physical trauma, which is a sudden or severe injury that causes medical problems that require medical attention. This is the type of trauma that we see in the emergency room every day. Next, we have psychological trauma. This is a reoccurring or prolonged harm to a person's emotional, physical, social, or spiritual well-being. Oftentimes, the psychological trauma occurs at the same time as the physical trauma. So let's think about a person who is experiencing a car or has experienced a car accident. Afterwards, they may be too afraid to drive in adverse weather conditions. It could be also a rape where we have a physical assault, or maybe even some schoolyard bullying. These physical events often also have a psychological component attached to it. However, psychological trauma can also occur without physical trauma. Psychological trauma only needs a threat of harm to be experienced. Psychological trauma can also occur through verbal abuse or even through the removal of care or affection. Another category of trauma is what we call adverse childhood experiences, or ACEs. The study of ACEs is the result of a landmark study that occurred in 1998. We have doctors Anda and Folletti. They conducted a study that included over 17,000 participants. Through their study, they discovered a correlation between 10 childhood experiences and several long-term health issues. These 10 experiences fall into 3 different categories: abuse, neglect, and household dysfunction. What's really interesting about ACEs is that the effects are dose dependent. So if someone experiences one of these, say sexual abuse, the health effects are not as severe as if somebody experienced all 5 of the household dysfunction experiences. It should also be noted that when somebody experiences a high number of ACEs, the negative effects can be mitigated through supportive relationships as well as resiliency. However, if someone experiences 6 or more adverse experiences before the age of 18, life expectancy can be decreased by up to 20 years. More recently, researchers have started looking at what they call the pair of ACEs. While we know through repeated and validated studies that adverse childhood experiences can lead to physical disease later in life, it makes sense that adverse community environments often accompany the original 10 ACEs. So when a child is experiencing adverse childhood experiences and also living in an adverse community environment, they will more likely develop unhealthy coping skills and are less likely to have a stable and caring adult in their life. And it's through that caring adult that the child is able to learn how to cope with with their adversity and to learn how to be resilient. With looking at all types of trauma, studies have shown that up to 84% of people encounter a traumatic life event at some point in their life. However, only 8% develop a diagnosis of post-traumatic stress disorder, or PTSD. Those who experience health issues, especially cancer, report ill effects of trauma related to their diagnosis. Studies show that up to 35% of patients who have experienced any type of cancer develop PTSD. This increases significantly for those who are diagnosed with breast cancer. Cancer survivors are almost twice as likely to have PTSD than someone who has never had cancer before. When the cancer is labeled terminal, then 82 to 88% of the patients consider the diagnosis extremely traumatic and often experience the high range of PTSD symptoms. When looking at patients being cared for within the ICU, up to 64% consider that experience traumatic. And if the patient experiences episodes of delirium while in ICU, they are more likely to consider the experience traumatic and develop symptoms of PTSD. So now let's look at how trauma affects the body physically. As part of our human survival instincts, our brain is always monitoring for danger. The amygdala is that area inside our brain that is constantly assessing for signs of danger. If it believes a threat is present, then the amygdala signals the hypothalamus pituitary adrenal axis, or the HPA axis. Then the hypothalamus, which is our command center, becomes alerted to the danger and activates the sympathetic nervous system. The activated SNS then tells the adrenal glands to release adrenaline, which then initiates that fight, flight, or freeze response. In preparation for fighting off or running away from a predator, the body releases and breaks down glucose to form ATP, which is then used for energy. As part of this metabolic reaction, hydroxyl radicals are released as waste products. The body also produces cortisol, which, if you think about it, makes perfect sense if, say, you're out in the wilderness and you're running away from a bear. Obviously, your fight or flight has been initiated. You are being chased. Cortisol floods your body with glucose that can be used for energy. In part, this occurs as a result of inhibiting the production of insulin so that the glucose can be available for immediate use. Cortisol also narrows the artery, while epinephrine increases your heart rate, and this increases blood flow. The goal is to deliver oxygen and fuel to your muscles. Hopefully, this will allow you to run faster and longer than typical to get away from that bear. Or at the very least, run faster and longer than your hiking buddy. Now, of course, cortisol also decreases inflammation, which is helpful if you should happen to trip over a tree root and twist your ankle while running away from that bear. Cortisol strengthens and solidifies fear-based memories, which then helps you to remember what you need to do to avoid the bear who was chasing you and trying to maul you to death. So cortisol is an essential part of the fight or flight response, and it is meant to ensure your survival. While cortisol is a positive adaptive response to short-term stress, such as that bear, as we will soon discuss, it is a maladaptive response when stress or a pain experience is long-term. So before we dive more into cortisol, let's take a quick look at those hydroxyl radicals. Hydroxyl radicals are released as glucose is broken down to be used for energy. Unfortunately, high levels of hydroxyl radicals can damage your body on the cellular level. We're talking all the way down to the DNA. We need healthy and complete DNA structures in order to be healthy. However, the DNA bonds within the mitochondria can break, and hydroxyl radicals attack the DNA bonds, causing some of them to break. As the DNA bonds break, more hydroxyl radicals are created, which then causes more breaks in the DNA, creating a vicious cycle. It's also important to note that the DNA within the nucleus can also be broken when attacked by hydroxyl radicals. These breaks can cause early cellular death. And as we all know, when our cells die early, we die early. Now let's go back and take a closer look at cortisol. The trauma our body believes it is under, if it's continual or a long-term threat. So as a result of this long-term threat, the body continues to release cortisol long past the actual moment of the threat. Cortisol also creates a reactive nitrogen species that damages DNA similar to those hydroxyl radicals. Also, with prolonged and high levels of cortisol, the immune system is suppressed, leading to frequent viral illnesses and other infections. The body also stores excessive belly fat, partially through an overactive appetite. High levels of cortisol can potentially be part of the reason food or overeating is used as a coping mechanism. In addition to overeating, cortisol tells the body to release large amounts of glucose into the bloodstream. This in turn leads to insulin resistance and ultimately diabetes. As a result of the complex interaction between all of the different effects of cortisol, hypertension can also become a health issue. With the long-term overproduction of cortisol, our patients can ultimately experience stress-induced cortisol dysfunction. In addition to conditioning the fear-based stress response the body experiences, an increase in pain, inflammatory, and autoimmune diseases. Which is why studies are showing that many who are diagnosed with things like fibromyalgia have a history of trauma and high levels of stress. Other signs and symptoms include bone and muscle breakdown, as well as depression, fatigue, and memory impairment. As mentioned earlier, cortisol facilitates fear-based memories, intensifying that experience. This occurs as a result of cortisol promoting the dendritic growth, which then strengthens that synaptic connectivity in the amygdala. Ultimately, this facilitates the formation of fear-based emotional memories by increasing the glutamate levels, upregulating NMDA receptors, and potentiating prolonged calcium uptake and increasing levels of brain-derived neurotrophic factor, or BDNF. Some studies have also reported that even non-pain related activation of this response may trigger pain even in the absence of tissue damage. This is important to recognize, especially when pain is part of the experience. So whatever is the cause of the excessive cortisol secretion becomes embedded into the memory and part of the conditioned and sensitized physiologic stress response. Additionally, due to the emotional dysregulation, which often accompanies trauma, the amygdala resists the calm and rational input from the prefrontal cortex. This maladaptive emotional response, in turn, increases the HPA axis activation, and that whole cycle continues on and on and on. As anxiety is a natural response to the activation of the HPA axis, it's not a surprise that numerous studies have reported that baseline anxiety scores are significant predictors to pain, depression, as well as a reduced quality of life. This is especially so when pain is the stressor. When pain is part of a fear-based memory, the pain experience is intensified. In addition to the physiologic stress response, maladaptive coping mechanisms often play a part of the pain experience. With the changes within the amygdala, emotional dysregulation is common. Often those who have experienced past trauma utilize what we call magnification and catastrophizing as part of their response to the pain. This in turn prolongs the stress response, elevates the cortisol levels, and ultimately increases their pain levels. Adverse experiences also lead to later life inflammatory processes. This can occur through either genetic predisposition or through epigenetic alterations. In addition to influencing pain outcomes, genetic and epigenetic changes can increase risks from the metabolically led illnesses and affective disorders. The process is multifactorial and genetic, with genetic, gender, epigenetic, and early psychiatric inputs. Basically, biological embedding. There are at least 3 systems involved in the activation and deactivation of our genes. DNA methylation, I can never say that word, methylation, histone modification, and non-coding RNA are associated with the silencing of our genes. So each of these processes are thought to initiate and sustain epigenetic changes. DNA methylation is simply the addition of a methyl group directly into the DNA strand at one of the 4 nucleotide bases that are found within our DNA. DNA methylation is a mechanism used by our cells to control gene expression. As a result of either genetic predisposition or epigenetic alteration, those who have experienced trauma, especially trauma early in childhood, have a higher risk of experiencing pain memory, an increase in pain-related anxiety, which activates that HPA axis, and an overall intense and prolonged pain experience. When someone experiences trauma, significant changes occur within the brain. The 3 areas primarily affected are the amygdala, the prefrontal cortex, and the hippocampus. The amygdala is the key nucleus that can integrate both stress and pain signaling. So chronic stress promotes an increase in dendritic branching out, as well as axonal connections within the amygdaloid neurons. all while concurrently pruning the dendrites and axon connections within the hippocampus and prefrontal cortex. So in simple terms, this means that those who have experienced trauma often have big emotions that are poorly regulated while lacking in the ability to think logically and make decisions. They may also suffer from an impaired memory. Oftentimes, the memories of those who have experienced severe trauma are like a book with the pages being ripped out. The pages become disorganized, resulting in a very disjointed story or history. This, in turn, can make obtaining that pain history, that pain assessment, very difficult. In fact, this lack of ability to string together a good history can sometimes be looked on as somebody who is making up a story in order to seek opioids or drugs, what we tend to call drug seekers. So now let's look at the psychosocial effects of trauma. In addition to the physical effects, those who experience trauma also suffer psychologically and socially. Because of the dysregulation, they often have an inability to cope with even normal everyday stress. And if the trauma is the result of abuse at the hands of others, especially, say, their parents or a close family member, a friend, somebody that they've had a relationship with, in the end, they will have difficulty developing trust with others. And as previously mentioned, they may have difficulty managing on that cognitive level. With the increased activity within the amygdala, they may have difficulty managing their behaviors and regulating their emotions. As a result, those who experience trauma have difficulty maintaining long-term relationships, and this includes the relationships needed to maintain employment. So now let's look at the pain and trauma connection. Studies have correlated several pain conditions with a history of trauma. Many are musculoskeletal, while others are related to the immune system. Some pain conditions are the result of physical stress through behaviors such as clenching your jaw, grinding your teeth. But interestingly, some pain conditions are without specific causes. So non-specific headaches or migraines, abdominal pains, pelvic pains, those types are experienced, but without signs of physical or actual tissue damage. When looking at adult onset chronic pain, there is a distinct correlation with adverse childhood experiences. When someone experiences 6 or more ACEs before the age of 18, they are 2 to 3 times more likely to experience chronic pain than someone with 0 or maybe even only 1 ACE. When looking at the type of pain, it's noted that those who experience diffuse pain are more likely to have experienced physical or sexual abuse. Depression and anxiety also increase with chronic pain. One multi-regression analysis has shown that the effects of ACEs on adult pain scores are independent of the mental illness. When gender is considered, women from all forms of mistreatment are associated with pain. This is possibly due to the psychodynamic processes such as catastrophizing and high anxiety levels. However, for men, only physical and sexual abuse are significantly associated with adult onset chronic pain. Evidence also suggests that stress and negative emotions have profound effects on nociception. As discussed earlier, childhood trauma leads to the dysregulation of the HPA axis, which then leads to chronic pain along with emotional dysregulation. So the emotional dysregulation then often potentiates negative emotions, such as catastrophizing, which then starts the cycle all over again, and it just continues on and on. As expected, those who have experienced trauma are also more likely to have experienced mental health issues. They are 4 times more likely to become an alcoholic or to inject drugs. This is especially important to note as this indicates an increased risk for addiction to pain medications. Numerous studies have also demonstrated that mental health factors are predictive in establishing pain chronicity and are often the driving factor of negative outcomes. Along with increasing disability, mental illness can also increase the cost associated with pain management. While historically providers have treated mental health separate from pain condition, today it is becoming more common to integrate the treatment programs. Now, as an academic and a nurse scholar, I would be remiss to not include a theoretical framework. I found that Lazarus and Folkman's model of stress and coping aligns perfectly with the management of pain for those who have a trauma history. When pain management is practiced using a model of stress and coping, the connection between mental health and pain is recognized. Lazarus and Folkman understood that people with a traumatic history tend to see things very negatively. This leads to catastrophizing the pain experience. Whenever they view an innocuous situation, they see it as being very dangerous or threatening. The effects of trauma also has an influence on coping efficacy. So the model of stress and coping states that stress is encountered when the relationship between the individual and the environment is assessed to be more than their available resources and then threatens their well-being. So when the perceived stress is greater than the individual's coping skills, their pain increases. Neither the environmental event nor the person's response defines the stress. Rather, it's the individual's perception of the psychological situation that is a critical factor. So according to Lazarus, the effects that stress has on a person is based more on that person's feelings of threat, their vulnerability, and their ability to cope than on the stressful event itself. He defines psychological stress as a particular relationship between the person and the environment that is appraised by the person as taxing or exceeding his or her resources and endangering his or her well-being. So the model of stress and coping focuses on a primary and a secondary appraisal of the situation. So the primary appraisal is affected by the individual's application of a personal importance to the encounter. So, for example, let's look at the current state of requiring people to wear masks. For the average person, wearing a mask is innocuous or at best an irritant, maybe an inconvenience. However, someone who has experienced certain types of trauma may find wearing that mask extremely stressful and even anxiety producing. When a young girl is sexually abused by a man, that man's chest covers her face. That man may also cover her mouth to keep her from crying out. Now fast forward into adulthood and the new requirement to wear a face mask. If the woman is having a relatively stress-free day, the primary appraisal of wearing a mask may only result in feelings of mild distress. However, if the woman is experiencing multiple stressors that day, the primary appraisal may result in feelings of being under threat, which induce those high levels of anxiety. So in simple terms, symptoms of PTSD were triggered by the requirement of wearing a mask. Now, the secondary appraisal incorporates the individual's associated internal and external demands, as well as the constraints, what available coping options, and the efficacy of those options. So in the first scenario, when the woman was having a low stress day, the secondary appraisal assured her that while she may be uncomfortable, she would be able to wear the mask. She could cope with the stress. However, in the second scenario, when the woman performs a secondary appraisal, the stress she felt was greater than her ability to cope. So in this case, if she were unable to change or manage her emotions to cope with the situation, she would have to change the situation itself. So in other words, she would need to recognize her day so that she would not, or reorganize her day so that she would not have to wear a mask. Health, energy, positive beliefs, problem-solving skills, social support systems are all examples of resources that affect a person's ability to cope. So as the resources may fluctuate day to day, so does one's ability to cope. Coping mechanisms should be either emotion-based, emotion-focused, problem-focused, or a combination of both. So,
Brenda, this is the 15-minute mark.
all right,
Just wanted to let you know.
thank you. So what does the model of stress and coping tell us about pain management? It tells us that pain perception is the key. As Lazarus notes, the interpretation of stressful events is more important than the events themselves. When this is related to pain, the perception and interpretation of the pain event is more important than the actual pain event. If we can help a person change their perception, we can help improve their pain. This can be accomplished through the inclusion of psychotherapy and social support. In the modern medical era, providers frequently their assessment focuses on the objective tissue damage that is correlated with the subjective pain response. They then tailor pain management therapies to correct that biomedical deformity or the injury. However, this approach leads to a suboptimal response from the patient, and patients with unmet needs may seek relief outside the medical community. This also ultimately leads to provider frustration and job dissatisfaction. Chronic pain must be approached as an interrelated biomedical, psychosocial, and spiritual phenomenon. Anything less is suboptimal treatment. So let's look at a case study. We have a 46-year-old female with a history of childhood trauma, diagnosis of PTSD, depression, and anxiety. Her pain situation, she had acute onset, which then led to chronic pain over an 8-month duration. So her initial pain episode was triggered by swimming 2 to 3 times a week for exercise and weight loss. The pain was located in the right neck and shoulder area, radiating down to the scapular area, as well as down the right arm. She was eventually started experiencing numbness and tingling to the right thumb, as well as the fore and middle finger. After several days, and with the onset of the numbness and tingling, she visited an urgent care clinic. The physician diagnosed her with cervical radiculopathy, prescribed Flexeril and Norco for pain. Her instructions were to follow up with her PCP. Her PCP agreed with the diagnosis of cervical radiculopathy based on the x-rays, and due to restrictions placed by the insurance company, a CAT scan or an MRI could not be performed until she completed 6 to 8 weeks of physical therapy. During the physical therapy visits, cervical traction was minimally effective, but the exercises just exacerbated the pain. Her PCP was very concerned about prescribing opioids, so the patient was continued on Flexeril and prescribed just 1 5-milligram tab of Norco per day at bedtime as needed. Eventually, at the patient's insistence, Neurontin was added and was moderately effective. Pain on average rated from 4 to 6, with occasional episodes rating between 8 and 9. At the completion of physical therapy, the patient had been living with the pain for over 3 months. Sleep quality was poor due to difficulty sleeping related to the pain. Work performance was affected. She reported anxiety related to fear of losing her job. A neurologist was consulted and an EMG was performed. The report stated the EMG showed nerve involvement, and he confirmed cervical radiculopathy. The patient was now approaching 5 months of consistent pain that was interfering with activities of daily living as well as affecting quality of life. I'm sure it won't surprise you to hear that this patient in this case study was actually me several years ago. I can report that pain, rumination, and catastrophizing occurred nightly. Anxiety and depression increased to the point of suicidal ideations. Norco was ineffective. Like most chronic pain patients, I began to try to find ways to alleviate my pain. My goal was to sleep because the sleep deprivation had gotten very severe by that point. In similar cases, sometimes patients will actually go and borrow opioids from friends and family members. In extreme situations, they may go and seek illegal substances. What I did was I skipped my daily Norco one night so that I could take, 2 tabs the second night in hopes that it would help me sleep. After finally getting insurance clearance for the MRI, I requested a referral to a neuroscience center at a large health system in a nearby city. After being seen by their physiologist, I was told that I had been misdiagnosed and that my pain was my shoulder, not my neck. I was then referred to an orthopedic specialist. I had been living with pain for almost 7 months at this point. Eventually, I did have surgery on my shoulder, and it was effective until the arthritis eventually returned. So now let's fast forward 6 years. My left shoulder is causing some moderate, sometimes severe pain. And I also have severe pain to my right shoulder. While I do occasionally have some rough mental health days, I have been able to cope significantly better this time around. I was told by my orthopedic surgeon that I would probably always have some pain in my shoulders and that the goal was to learn how to live with the pain until I couldn't. Now, strange as that sounds, being told that was a game changer for me. Knowing that I was going to have to live with that pain and that it was expected shifted my thinking. I no longer felt a drive to make the pain go away. Too often our patients think that pain needs to be at 0. Well, no, we are not going to completely alleviate pain, and especially in my case. That goal was an impossible goal. So I finally understood that some level of pain was just going to be part of my life, and I needed to make friends with it. The pain was part of me. I learned to live with it, and I still have some quality of life. So I have been able to apply what I have learned about coping and pain perception. I use things like audiobooks, podcasts for distraction, along with mindfulness. I use some prayer meditation in order to prevent my rumination, especially at bedtime or if I wake up in the middle of the night and I'm hurting. I need something to get my mind off my pain. I've also started using other holistic measures, such as massage therapy for me works well. I use essential oils, CBD. I'm not able to take NSAIDs, so that's a problem. But CBD has been a definite game changer for me, and it's helped me sleep. I've also discovered simple things like the type of pillow I use can affect my pain at night. My pain's actually to the point now where I sleep in a recliner chair, but I've learned that being up versus, having my head elevated versus laying flat has a huge difference in my my pain, so now I can at least sleep, and sleep gives me a better quality of life during the day. So as far as the, sorry, I got distracted there with that. Understanding how previous trauma affects my response to pain and then taking measures to change my response has improved my pain. Also, being able to apply coping measures and other holistic interventions has empowered me. It's allowed me to take control over my situation. And those who have feel like they are more in control of the situation are less likely to experience anxiety. And as we have learned, decreased level of anxiety improves pain management. So how does one assess for trauma when providing pain management? We have 4 options. We can assume a history of trauma, very similar to universal precautions with bloodborne pathogens. Just work with everybody as if they have some sort of trauma. Or we can utilize some sort of structured tool. Option 1, as I mentioned, I believe should be utilized just like universal precautions. We should assume that history of trauma unless we learn otherwise. I think as a whole, healthcare should just use trauma-informed approach with everyone as a standard practice. Patients can also be screened for trauma through physical assessment and the use of open-ended questions. If indicators of past trauma are noted, then a simple tool can be used to confirm that assumption. Now, an ACE questionnaire can either be written or, where a patient fills out a form, check some boxes, or you can just use an infographic. It's also not uncommon to just show the patient an infographic after it's been explained and just ask for the number of experiences that they've had before the age of 18. By doing this, the patient provides a number and then eliminates the discomfort that goes along with trying to explain their past experiences or being specific about what type of trauma they have experienced. The other tool that can be used is called the PAIR tool. This tool was developed by Dignity Health out of California in collaboration with Heal Trafficking. The slide provides the URL where you can obtain a copy of the tool along with instructions on how to use it. The basic premise of this tool is to educate the patient in a manner that is non-judgmental and normalizes the sharing of information. If the patient denies past traumas or victimization, declines assistance, then we definitely need to respect their wishes. But if they do accept assistance with accessing services, we want to provide personal introductions to local advocates or different service providers. So the trauma-informed approach. Once it's been identified that a patient has a trauma background, it's important to utilize a trauma-informed approach. People with trauma histories tend to struggle with behavior change. They may shut down or withdraw from those providing care. This may lead to avoiding appointments, or they may be very emotional and become angry very easily. So with emotional dysregulation, people tend to only seek help when they are in crisis. This can lead to failure with follow-through. Providers may assume that trauma-based behaviors are due to a lack of motivation, disinterest, maybe even a failure to take pain management seriously, or they may just think that they're being manipulated and the patient is being rude. In reality, patient withdrawal or assumed disinterest may actually be an attempt to self-soothe when they're triggered emotionally. Inaccurate assumptions lead to poor outcomes or patient dissatisfaction. This can also contribute to provider frustration and burnout due to increased stress and poor job satisfaction. These inaccurate assumptions and poor patient outcomes can be avoided through the use of a trauma-informed approach. The perspectives from which trauma is addressed or how treatments are implemented contributes to the outcomes for the trauma survivor as well as the individuals providing the care. The trauma-informed approach is non-judgmental, and is patient-centered. Instead of asking what is wrong with them, it asks what happened to them. A trauma-informed approach prioritizes safety while educating and empowering. Due to experiencing high levels of stress and anxiety, it's important to ensure the patient feels safe within the physical environment. This may mean offering to have another person in the exam room or asking if they want the door open or closed. If someone has a history of assault or abuse, they may feel trapped if their means of escape is blocked. Helping them feel safe may be as simple as moving off to the side and sitting down before interacting with them. Empowering the patient includes incorporating patient preferences into the plan of care. We also need to be willing to anticipate or notice signs of distress. When the patient is uncomfortable or distressed, we need to address it with them. This allows us to identify barriers as well as facilitators to their pain management. When it comes to providing pain management services to those who have a trauma history, it's important to understand attribution and reframe your assumptions. We need to understand that the cause for the reason behind their behavior. Consider the patient who needs to be weaned off opioids after a significant period of time. The patient with a traumatic past may become emotionally dysregulated, angry, or aggressive when told that this is necessary. We need to recognize that this patient is experiencing a lack of control related to their situation. This lack of control creates fear reminiscent of past trauma. The patient then lashes out in response. They have dysregulated, angry, aggressive, manipulative behaviors and become difficult to work with. They may discontinue their care and they may start to doctor shop. If the provider reframes their assumptions, they may recognize that the individual is trying to get their needs met, although very maladaptively. The provider can then use the knowledge of the patient's fear and lack of control, fertilizing a commitment to work with the patient and establish a schedule that engages the patient by selecting alternative modalities. Consider the patient who fails to follow through with a referral to physical therapy. Without using a trauma-informed approach, the provider may dismiss the patient and abandon efforts to engage the individual. The assumption is that the person is indifferent or disinterested in their pain management plan of care. With the use of a trauma-informed approach, the provider might explore the barriers that the patient had. They may discover fears related to the physical therapy setting, maybe the gender of the therapist, or maybe even a fear of being touched by a stranger. Understanding these barriers allows the provider to address them directly and identify alternate options. When working with pain patients who have a history of trauma, assessing for trauma and utilizing a trauma-informed approach has many benefits. It allows for the optimization of the pain care, reduces their fears to the treatment plan, and allows for the development of the trust relationship while encouraging collaboration through empowerment. Studies show that those with a trauma history are more likely to experience chronic pain than those without trauma. So statistically, it is likely that many of our pain patients have suffered from past adverse experiences or traumas. While everyone with a chronic pain does not have a history of childhood trauma, treating all patients as if they do is just good patient-centered care. Thank you for attending this presentation, and I hope you found it very informative. Now we will open it up for questions.
There's a question in the chat box, Brenda. Somebody said, I think we have many such students now starting to come to college. Where, how, who at our colleges can help these students appropriately? Do you have any ideas on that?
Yeah, I see it as well. You can actually become a trauma-informed education setting too. This doesn't have to be just healthcare. You also have your counseling department. You can work with them, find out what resources are available. But a lot of it goes along with how you approach them in decreasing anxiety. I personally believe that if our students have high anxiety, they're gonna score low on their tests because their hippocampus isn't working as well and their prefrontal cortex isn't working as well. And so decreasing the anxiety related to nursing school, I think, is a huge start.
Thank you.